thalassemia quality of life instrument. The impact of thalassemia major and thalassemia intermediate and their associated complications on quality of life, as we all know, is largely unknown. So determining the degree of health impairment as perceived by the patient is essential information needed to recommend suitable therapy. With the availability of better transfusion regimen, iron chelation therapy, proper management of complications and good supportive care, it's now possible for thalassemia patients to have a near normal lifespan with a good health-related quality of life. Up to now, improvement of patient life is accompanied by significant ongoing health care needs related to the chronic condition. Simply surviving is not sufficient. The quality of survival has emerged as a fundamental focus of comprehensive health care. Determining the degree of health impairment as perceived by the patient is essential information needed to recommend the suitable therapy for doctors. So for the future, health-related quality of life should be considered an important instance of effective health care in thalassemia. But we know that there is very little published work on evaluation of health care. Now, how do we measure quality of life in thalassemia major? Till now, no specific questionnaire on thalassemia patients' health-related quality of life exists. We know that the SF36 is up to now the most used measurement, but it's not specific. It's a generic health-related quality of life measurement. So the aim of our study was to develop, according to the psychometric standards, of self-administered specific for thalassemia quality of life instrument, the SD quality. We had two phases in our study. First was a qualitative study and then a quantitative. The first step of our study led to a 60 items questionnaire, and the second phase led to a 35 items questionnaire and 3 global questions. In our first step, the qualitative phase was conducted to generate the items, to identify domains using the critical analysis, incident technique, and literature review. A list of easily comprehensive non-redundant items was defined with the DOFI technique and a pilot study on 10 patients. This phase also involved experts, doctors, psychologists, social workers, and hematologists, and nurses. The ethical board committee of our hospital approved the final protocol. The questionnaire was anonymous in order for the patient to be able to answer with no hesitation. Every questionnaire was assigned a code number in order to be able to perform the statistical analysis, and every questionnaire were returned in a closed envelope. Then, in the second step of our method, there was the quantitative validation phase in thalassemia patients. This phase was designed in order to select the items from the 60 first questions, to identify the dimensions that we were going to measure reliability, internal and concurrent validity. Patients were randomized according to the day of questionnaire completion, meaning the patients that were coming in our transfusion department for blood tests versus those that came for a transfusion. And the participation rate was 94%. The validation process. Statistical analysis was performed using SPSS for Windows 16. Analysis of the relationship between the independent variables and health-related quality of life were performed in order to establish those variables associated with health-related quality of life. Then, exploratory factor analysis using principal axis factoring with an orthogonal variance rotation was conducted to the sample for each domain independently for sampling reasons. What kind of questions did we use? First, we had the new SD quality, the 36-item questionnaire. One global item about perceived general health, with 1 to 5 categorical answers with bad health to very good health. One global item about mental health, in the same categorical values, and one global item about satisfaction with chelation therapy. Also, we give the SF12, which is the short form of the SF36 questionnaire, and a questionnaire with demographic variables for our sample. So, our sample was consisting of 85 patients with thalassemia major. The age group was between 20 to 62 years old, with a median of 37.17 and a standard deviation of 9.3. 34 of them were males and 47 were females. Some of them did not specify their gender. Probably they were afraid. The first domain is the psychosocial domain, and factor analysis shows us 4 factors with somatic symptoms, psychological symptoms, state, social. Then we have the declination domain with 3 factors. Transfusion impact domain with 2 factors, one about the transfusion and the other one about the fear of the patient due to the transfusion. And the disease and symptom domain with 4 factors. And questions about everything about the disease and symptoms. Then, internal consistency of the questionnaire. Internal reliability coefficients for the total scoring in 4 dimensions were calculated independently and were found satisfactory for the total questionnaire and the 4 domains. We see that the total variation explained we have 72, 64, 58, and 65. The first domain had 11 questions, the second 7 questions, 6 questions for the transfusion domain, and 11 questions for the psychological domain. 35 on the total amount. We then had interscale correlations, which were between 0.27 to 0.64 in all domains. Conventional validity was evaluated with the PS12 and MS12, it's the physical mental score and the scales of ESF12. Bivariate analysis did test ANOVA, Pearson correlation coefficient as appropriate when they performed in order to evaluate the relationship between the independent variables and health-related quality of life, as it was measured with a new questionnaire, 4 domains. We found that men and women had a significant difference in the psychosocial domain and in the disease and symptom domain, with women having lower mean scores. How do we see this test? The present quality of life is assessed in patients responding in its domain. The sum of every domain is transformed in a 0 to 100 scale in order to be easily compared with the global measurements of quality of life, the SF36, the SF12, and the Europol. Higher values indicate better quality of life for each scale. 90 to 100 is the optimum score, and it's one goal for our patients. That's what we hope for. The results of our supplements is other deviations. We see that the best factor for our patients was the chelation impact domain with a mean of 79.7. On the other hand, psychosocial impact domain was lower with a 66.9. As you can see, the physical component score and mental component score of the SF12 is almost a little less than the general population with a median of 46. And in the total questionnaire, the median was 72.6. Our global satisfaction, the majority of our sample thought that they had a very good and good quality due to the chelation therapy. Then, in the global self-evaluation of the general health, 52% of our sample thought that they had a good quality of life, 19% thought that they had a very good quality of life, and practically 25% thought that they had a moderate quality of life. Concerning mental health, 40% of our patients thought that they had a good quality of life, and 28% thought that they had a very good quality of life. But is it stable? What did we find with the domains of the EST quality? In general health domain, we found that 87.6% of our patients had a score lower than 90. So we are hoping for more. But 29.4 had a very good quality of life, 48.2 had a good quality of life, 18.5% had a moderate quality of life, and 1.2 had a very bad quality of life. It's stable with the general, with the global item. In the psychosocial domain, 24.7 thought and found that they had a very good quality of life, but 31.8 had a good life, and 31.8 had a moderate quality of life. But in the global item, they thought that they had very good life. So even if they believe that they have a very good quality of life in the psychosocial domain, we found with the questions that they don't have what they think they have. chelation therapy domain, 81% of our patients had a score lower than 90, but as you can see, the 45.9% had very good quality of life, meaning that we have something good in our department. So, the transfusion event. 90% of our patients have a score lower than 90. But we see the majority that is between good and very good. In the total score, the majority of our patients thought that they had a good quality of life and a very good quality of life. And they did with most statistics. We then had the Pearson and Spearman toleration coefficients as appropriate. As you can see, the four domain scores correlate significantly and moderately with each other between 0.415 to 0.692. And they were all strongly related to the ST quality. What we see is that AIDS has a significantly strong negative correlation with almost all the domains of the patient. So, the conclusions. It seems that the 35-item specific thalassemia quality of life instrument is a valid tool in assessing health-related quality of life for patients with thalassemia. Of course, further explanation, international research is suggested in order to explore the universal properties of the questionnaire. Since thalassemia has become another disease in the third AIDS, special consulting programs should be created for all the patients. And a take-home message. Chelation impact, which was our stronger factor in health-related quality of life in patients with thalassemia, had a significant positive correlation with the psychosocial impact scale. This means that the better quality of life patients have with a given chelation therapy, the less anxious and depressed they will be feeling. Thank you.
We have a couple of minutes for questions. Any questions? It's on.
Hello?
It should be on.
Okay, well, I'm from London, and thank you. That's quite an interesting subject. You know, all of us are excited about it. The quality of life assessment that we use in terms of the tool, how was it unique for thalassemia as against chronic illness and also possibly sickle cell disease? But however, what I'm actually suggesting is that if we could have something that is probably common for thalassemia and sickle cell disease, but I feel I'm quite anxious because I'm doing some studies on quality of life, and I've tried to actually compare chronic illness, sickle cell disease, and chronic renal failure. But I want to see what is it that will be very specific for these two conditions, thalassemia especially. What is specifically in your menu?
We have chelation impact. We have four domains that concern only thalassemia. We have interviews with patients and experts, and we learn about the bibliography, which is the factors that are affecting thalassemia. And then we have the items that concern only thalassemia. That's why it is specific for thalassemia. The other measurement, SF36, have general questions about quality of life, and they have domains such as mental health, general health, physical fatigue, but they have no questions about chelation therapy, transfusion impact, the way that the body image is affecting quality of life of the patients. That's how it's specific for thalassemia. It has questions that are concerning patients only with thalassemia.
So I was just wondering that chelation and transfusion would go for sickle cell disease. I just want to whether some more kind of discrimination.
This is our next step to include patients with sickle cell disease. But this was only in patients with thalassemia major.
Well, sorry, can I ask you though, there could be a problem with sickle cell disease because they might have different morbidities that have occurred prior to their starting chelation.
Yeah, that's true. Obviously, if you think about sickle cell disease, there are more discriminating factors than you would think about thalassemia. It's quite probably more tricky. But in sickle cell disease, you have things that probably more specific to sickle. And there is an ongoing study in the US which is trying to look at adults with sickle cell disease to try and develop a menu of quality of life that's going to be specific for sickle cell disease. And I think it's something that probably need to look at very closely to be sure that, because more or less describing a good number of patients with sickle cell disease who are on chelation, on blood transfusion, because those are the two most important factors for them.
Thank you. I have a question. I have some difficulty trying to see what your control group, or how you can measure what you've done against other people, or healthy people, or say diabetics, or something like that.
We could only do that with the SF12. We know that we have the numbers from Mr. Nyaka, the Greek population, that the general population has a mean of 50 in general population, and it's about 40 diabetic people. But in our patients it was 46, the median was 46, so we know it's a little bit less than in the general population. But we can have another group answering these questions. That's a problem. Only patients with thalassemia can answer these kind of questions. Okay. So we had only the SF12 to compare with the other people, the general population. That's why we used this generic measurement.
And is there any comparison in your chelation activity with respect to what chelator the patients get? Or what form of chelation?
Yes, it was, but due to the fact that we have only 12 minutes to present our study, I wasn't able to put them in the slides. But there was not a very significant difference between the chelation therapy and quality of life, and this was because one of our chelation therapies had very few.
Okay, thank you very much. Now, call on Dr. Lyrakos.mp4, who is the Chief Thalassemia Unit at the Hospital in Italia.